All right. Welcome, everyone. My name is Haley Buckner, and I'm the Professional Relations Manager for Elevate Oral Care. Thank you for joining us this evening. Before we start, I'd like to cover just a few housekeeping items. For those of you remaining online past 50 minutes, your CE certificate will be emailed within hours of the completion of this talk, so be sure to check your spam folder. You're all muted, so no need to worry about background noise. We will have time at the end for questions, so be sure to submit your questions on your webinar dashboard. They will be tracked throughout the talk. We have hosted an extensive series of free, live, continuing education webinars on many different prevention topics. Each of these webinars were recorded and are available with free self-instruction CE at the web address elevateoralcare.com/elevatingcare. Be sure to bookmark this page and return often to see what's new in free CE. And also, if you have a topic that you would like to see covered, feel free to suggest it by sending an email to info@elevateoralcare.com or by completing the webinar survey that will be sent out after the completion of the talk this evening. For tonight's talk, though, we are honored to have Dr. Ronnie Brown. Dr. Brown earned her dental and master's degree in public health from UCLA and completed a residency in dental public health from UCSF. Her research on the effects of drug use patterns on meth mouth severity has garnered national interest and positioned her as a leading expert on the oral effects of methamphetamine. She is an international speaker and author of the bestseller, A State of Decay, Your Dental Guide to Understanding and Treating Meth Mouth. Dr. Brown practices in Santa Rosa, California. I'm excited to turn it over to you, Dr. Brown. Thank you.
Thank you. Well, welcome to Catching Up to Speed. I want to first say good morning, good afternoon, or good evening based upon where you might be in the world today. But wherever you are, today we're going to be talking about one of the most important and one of the most relevant topics in dentistry, that being addiction, and specifically an addiction to methamphetamine. In the webinar today, you're going to learn what methamphetamine is and why this drug is so addictive. And then you're going to learn how to detect the clues of methamphetamine abuse during a routine dental examination. You're then going to learn how to discuss your concerns and your suspicions with your patients. And then I'm going to share with you how to treat patients who have the oral effects of methamphetamine in ways that are safe, appropriate, and realistic. I would like to thank Elevate Oral Care for sponsoring today's webinar. So before we talk about what methamphetamine is, I think it's important that we talk about what addiction is, because you see, it's how you understand addiction that's going to determine whether your treatment of a patient who is addicted is appropriate or just plain silly. Now, addiction is part of a larger umbrella term, which is known as a substance use disorder. And a substance use disorder is a disorder in which someone is using a drug in a way that's inappropriate, which means they're using a drug in a way it was never intended to be used. They're using the drug excessively, both in frequency and in quantity. And they're also using the drug dangerously, because every time they smoke, snort, or inject the drug, they are putting their lives at risk. Now, in order for an individual to be diagnosed with a substance use disorder, they have to fulfill at least 2 out of 11 criteria established by the Diagnostic and Statistical Manual of Mental Disorders. And these criteria include when someone is using a drug, even in a situation that's dangerous. So, for example, they're having that drink and then getting behind the wheel of a car. They're using the drug even though they're experiencing a decline in their physical and their mental health. They're using the drug even though it's destroying the relationships that they have with their friends and their family. They're using the drug even though it's making it difficult for them to fulfill the obligations that they have in their lives. And their use of the drug is worsening or escalating a legal situation. Now, their use of the drug has become a problem because they built up a tolerance to the drug. And when they're not using the drug, they experience withdrawal symptoms. They began to use more of the drug than they had ever intended, and for a longer period of time than they had ever anticipated. And they're having difficulty not using the drug. Now, when we look at these criteria, using the drug in a situation that's harmful, it might make one think that, I don't know, addiction is just a bad choice that somebody makes. Or using more of the drug than one had intended for a longer period of time than one had anticipated, it might make one think that addiction is, I don't know, maybe just a lack of self-control or a lack of willpower. Well, addiction is much more than a bad choice that somebody makes. Addiction is a disease, and it's been recognized as a disease going back to 1956 by the American Medical Association. The most current definition of addiction comes from the National Institute on Drug Abuse that defines addiction as a chronic, progressive, relapsing brain disorder characterized by compulsive drug seeking and drug use despite adverse consequences. And it causes functional changes in the parts of the brain involved in the regulation of self-control, reward, and stress. And like other diseases, when left untreated, addiction results in disability. Like other diseases, when left untreated, addiction results in impairment. And like other diseases, when left untreated, addiction results in death. And in 2019, more than 70,000 Americans lost their lives from an unintentional drug overdose death. Now, that's a staggering statistic, but it's also a pre-pandemic statistic. Because as we've all known, in 2020, a global pandemic converged on our nation's epidemic of addiction. And by the end of 2020, there was a 29% increase in drug overdose deaths in this country, representing the single greatest increase in drug overdose deaths ever recorded in our nation's history. In May of this year, the CDC released drug overdose death data for the year ending in 2021. And unfortunately, we saw another spike in drug overdose deaths. Now, the majority of those deaths have been attributed to opioids, followed by methamphetamine, cocaine, benzodiazepines, and antidepressants. Since 2019, the deaths due to methamphetamine have more than doubled, and methamphetamine now surpasses opioids as the leading cause of drug overdose deaths in many Western states. So what is methamphetamine? Well, methamphetamine is a very powerful, a very addictive, and a very dangerous central nervous system stimulant that on the street is known as crystal, crank, speed, chalk, and ice. Over the years, I've asked my patients, why do you use this drug? And the responses seem to boil down to this. People use methamphetamine because they believe that it can, quote unquote, fix any problems that they have. My patients have shared with me that if they were feeling lonely, they would snort a little meth, and within minutes, they would become the life of the party. If they were feeling depressed, they would smoke a little meth, and within minutes, they would experience intense euphoria. They even told me if they were feeling unattractive, they would inject some meth, and within seconds, they would feel sexy and alive. And it's this illusion that methamphetamine fixes problems that has resulted in an epidemic and a crisis that is unprecedented. The impact of methamphetamine can be seen around the world. According to the United Nations Office on Drug Use and Crimes, there are 27 million people around the world who report using methamphetamine every single year. And with 27 million people using the drug, it's positioned the drug as the second most widely abused illegal drug in the world. Here in the United States, according to the National Survey on Drug Use and Health, there are 2.5 million Americans over the age of 12, who report using methamphetamine within the last 12 months. And then we have impact at the local level. Methamphetamine is the leading law enforcement drug-related problem. Now, let me unbundle that a little bit. When someone is arrested, when they're brought into custody, they're tested to see if they're under the influence of a controlled substance. The majority of arrestees from California to New York, from Alaska to Texas, show positive test results for methamphetamine because this is a drug that's highly linked to criminal behavior. Now, there are a number of reasons why methamphetamine has reached such an epidemic level. One of those reasons is that it's a drug that is very easy to make. It's made out of common household ingredients that are very acidic, very corrosive, ingredients that might be in your house right now. If you go into your garage, you might find some battery acid, some lantern fuel, and even some garden fertilizer that contains ammonia. If you go into your kitchen, under the kitchen sink, you might have some drain cleaner. And you might have that messy kitchen drawer where there's lithium batteries and matches that contain red phosphorus. And then when you go into your medicine cabinet, you might have cold or allergy medication that contains pseudoephedrine, ephedrine, or phenylpropanolamine. When those ingredients are put together, they can be put together in a kitchen, in a workplace bathroom, in the trunk of a car, in a motel room. Within 10 minutes, methamphetamine is manufactured. The majority of methamphetamine is manufactured in super labs in Mexico. And they have replaced those ingredients, the pseudoephedrine, the ephedrine, and the phenylpropanolamine, with a more potent chemical called phenyl-2-propanone, which makes a more addictive form of the drug. And now about 91% of methamphetamine that's seized in this country contains P2P as its active ingredient. So it's a drug that's very easy to make. But another reason why methamphetamine has reached such an epidemic level is that it's a drug that's very easy to acquire. It's a relatively inexpensive drug. On the street, methamphetamine retails for about $15 to $25 for a quarter gram. And with a quarter gram, the individual will have enough to smoke 2 pipe loads of the drug and even enough left over to inject. And every time someone takes a hit of methamphetamine, it produces a high that lasts anywhere from 9 to 12 hours. So I wanted to very succinctly establish for you what addiction is and what methamphetamine is. And with that foundational framework, I think I'm now ready to share with you how to begin to recognize the signs of methamphetamine abuse from a routine dental examination. Now, in order to recognize who in your practice may be using methamphetamine, I need to take you on a quick, hopefully a very painless trip back down memory lane to that time when you're a dental student or a dental hygiene student or even a dental assisting student, and you sat in a pharmacology class. And you probably remember learning about neurochemicals. And you might recall that neurochemicals are our brain's chemical messengers. They tell us how we should think, how we should feel, and how we should respond. And once we think a certain way, we feel a certain way, we respond a certain way. The brain then takes those neurochemicals and stores them back into their cells. Well, methamphetamine disrupts that process, because methamphetamine is able to bind to specific neuroreceptors in the brain, triggering the release of neurochemicals. And as those neurochemicals are being released, methamphetamine simultaneously blocks the brain's ability to store them. So you have a release system that's been activated, and you have a storage system that has been deactivated, and it results in a massive bioaccumulation of neurochemicals. Now, the neurochemicals that methamphetamine impacts are 4: dopamine, epinephrine, norepinephrine, and serotonin. Methamphetamine's main impact is on dopamine. And dopamine is a neurochemical that communicates a feeling of pleasure. So whenever you do anything that makes you feel happy, it's because dopamine has been released. Well, methamphetamine is a major disruptor of the dopamine system, and it disrupts it in 3 ways. The first thing that methamphetamine does is it binds to dopamine receptors, triggering a massive release of dopamine. Now, when I use that word massive, I'm not using that word figuratively. I'm actually using that word literally. So let me give you a little bit of perspective. At any given moment, on any given day, we have about 100 units of dopamine floating around in our brain. When someone drinks alcohol, and for many people, alcohol creates a feeling of pleasure, it's because alcohol can bind to dopamine receptors, causing the dopamine levels to jump from the base level of 100 units to about 200 units. When someone snorts cocaine, and cocaine creates a very intense euphoric feeling, it's because cocaine can bind to dopamine receptors, causing the dopamine levels to spike from the base level of 100 units to about 350 units. But when someone smokes, snorts, or injects methamphetamine, methamphetamine also binds to dopamine receptors, causing the dopamine levels to skyrocket from the base level of 100 units to 1,250 units. Methamphetamine triggers more release of dopamine than any other drug, creating a profound euphoric feeling. Now, as this dopamine is being released into the synaptic cleft, methamphetamine then inhibits a reverse transport mechanism that under a normal situation would take that released dopamine and reverse it back into its neuron for storage. So now you've got a storage system that has been impacted. And then to add additional fuel to the fire, methamphetamine inhibits an enzyme called monoamine oxidase, which under a normal situation would enzymatically degrade any residual dopamine in the synaptic cleft. So once again, you have a release system that's been activated, a storage system that has been inactivated, and an enzymatic degradation process that has been incapacitated. It results in a profound and a prolonged high that can last anywhere from 9 to 12 hours. Now, the elevated levels of dopamine had many positive effects for the individual. Once again, prolonged and profound euphoria. But the elevated levels of dopamine also increase the confidence of the individual. They feel as if they have liquid courage coursing through their veins and they appear to be invincible. The elevated levels of dopamine increase the sociability, so the individual does become the life of the party. But the elevated levels of dopamine have many negative effects for the individual. Many play out in the oral environment. The elevated levels of dopamine cause hyposalivation. The elevated levels of dopamine activate the neuromusculature of the temporomandibular joint, causing bruxism. And the elevated levels of dopamine cause sugar cravings. And I'll speak about those oral effects in just a few minutes. So methamphetamine's main impact is on the dopamine system, but it also activates norepinephrine as well as epinephrine, neurochemicals that are part of our sympathetic nervous system, part of that fight or flight reaction that we have. Now, methamphetamine does not trigger the release of epinephrine, nor does it trigger the release of norepinephrine. But when these two neurochemicals are kind of naturally present in the nervous system, in the brain of the individual, methamphetamine prevents those neurochemicals from being stored. So as a result, the individual has a kind of persistent and a prolonged presence of both epinephrine and norepinephrine. So what does that look like when you have a lot of epinephrine just kind of persistently present in your system? The individual will have bounds of energy. They'll become very energetic physically, where they have a difficulty sitting still. They'll be very energetic behaviorally and have a very rapid speech pattern. You will see an increase in metabolism. So they might experience hypothermia and be excessively sweating. They also will experience appetite suppression. And that is one of the main reasons why people begin to use methamphetamine, because it will allow them to lose weight. You'll see activation of the cardiovascular system. We'll see increases in blood pressure, increases in pulse, and you'll even see pupils that are dilated. Norepinephrine, on the other hand, is a neurochemical that helps to control our sleep-wake cycle. It also helps to control our state of arousal. So when I think of norepinephrine, I kind of think about it like our body's natural caffeine. Think about how you feel when you have your favorite, matcha cappuccino at Starbucks, right? You feel more awake and you feel more alert. And that's exactly what norepinephrine does when someone is under the influence of methamphetamine. They are more awake. In fact, sometimes they're awake for days. And while they're awake, they'll feel more focused and they'll feel more alert. And that's why we see stimulants being abused on academic campuses. It's estimated that about 7.5% of all high school students and 1 out of every 3 college students is abusing either an illegal or a prescribed stimulant because they can pop an Adderall or smoke some meth during final exam week, and it'll keep them awake for their studying. And while they're awake, they'll feel very focused and they'll feel very alert. Now, the fourth neurochemical that methamphetamine impacts is serotonin. And serotonin is a neurochemical that helps to regulate mood. It's a mood stabilizer. It also helps to control sexual impulses. Methamphetamine actually blocks the release of serotonin. So when someone is high on methamphetamine, they have very low levels of serotonin in their brain. And as a result, their moods go from stable to unstable. They experience bouts of anxiety that sometimes don't match the clinical scenario. The anxiety can easily morph into paranoia. They can start developing visual and auditory hallucinations and develop psychosis. So by understanding the pharmacology of methamphetamine, it allows you to begin to recognize some of the physical and the behavioral clues of abuse. A patient whose eyes are dilated, elevations in blood pressure, signs of paranoia, profuse sweating. But what does it look like now when someone's been using meth maybe for 5 years or 10 years or even 15 years? What happens is the individual goes through a transformation. They go through a physical transformation. They go through a behavioral transformation. But one of the most recognizable transformations is what you see in the mouth. And that's what's known as meth mouth. By definition, meth mouth is the rapid development of dental decay that occurs in individuals who are using methamphetamine. You see caries that's blackened. You see enamel that's so demineralized it appears to be crumbling. The caries can be so advanced that the teeth have fractured along the cervical margin. And the caries is so generalized that sometimes it can only really be described as rotted. You see a lot of smooth surface involvement, a lot of class 3 and class 5 lesions. And you also see a lot of anterior tooth involvement. But how do you know when a patient opens their mouth? How do you know that what you are seeing is due to methamphetamine? Well, I'd like to walk you through a clinical scenario that you may have already experienced. And I'd like to point out to you when you should suspect that what you are seeing is due to methamphetamine. So let's go back to maybe that scenario where it was 9 o'clock in the morning and you have a new patient exam, and it's a 20-year-old patient. And when she opens her mouth, you see a lot of class 5 lesions. Now, I hope that this strikes you as a little bit odd, because I think we can agree that class 5 lesions are fairly atypical in a 20-year-old. We typically will see class 5 lesions in someone who's over the age of 40, who's experienced a decline in the periodontium, gingival recession, root surface exposure. But now you have a 20-year-old in your chair with no clinical attachment loss, yet class 5 lesions. This is very suggestive of methamphetamine use. And then you take a look at the color of the decay. It's blackened. Now, caries is typically not blackened. It's usually, brownish, might have a little yellowish or orange hue to it. But when someone is putting battery acid and lantern fuel into their mouth, it creates a chemical burn of the enamel. Blackened decay is very suggestive of methamphetamine abuse. And then you take a look at where the caries is occurring. Now, caries is typically, I think, a logical disease process. We typically see caries on the posterior teeth. Why? They're early eruptors in the oral environment. They have a morphology that's full of pits and grooves that trap carcinogenic bacteria, and they're positioned where it's very difficult to access for oral hygiene. But now you have a 20-year-old patient in your chair with advanced caries on a lateral incisor. Overall, our anterior teeth are at much lower risk for caries. This is very suggestive of methamphetamine use. So let me go back to the pharmacology, because the pharmacology will explain the blackened decay, the smooth surface involvement, as well as the anterior tooth involvement. So you've learned that methamphetamine causes a massive release of dopamine. Elevated levels of dopamine stimulate the alpha-2 receptors in the sympathetic nervous system. And when those alpha-2 receptors are stimulated, it causes vasoconstriction of the salivary glands. And about 80 to 85% of methamphetamine users report experiencing xerostomia during their drug use. Now, this vasoconstriction, this decrease in salivary flow, is occurring at the worst possible time, a time when battery acid and lantern fuel is coming into the oral cavity. So the individual loses their capacity to neutralize that acidity. And as a result, the salivary pH drops. And when the salivary pH drops, the enamel begins to demineralize, which is a precursor for the development of dental decay. In the research that I did in collaboration with UCLA and UC San Francisco, we had a population of patients that we were able to divide based upon their own self-report into methamphetamine users and non-users. The first thing that we did was compare the amount of decay between those two groups. And we found that our population of methamphetamine users had statistically significantly more teeth that were decayed than our population of non-users. Now, that finding of higher levels of decay amongst methamphetamine users was not unique to our study. It's been published previously, but it did help to kind of corroborate previous research findings. We then honed in on our population of methamphetamine users. And we observed that in that population, there were some participants who had very little decay in their mouth. And then we had other participants where every single tooth was decayed. So we became curious as to what was driving what we defined as meth mouth severity. And we began to look at the patterns of drug use. We looked at duration of use, frequency of use, amount of use, primary route of administration, as well as if they were co-abusing with alcohol. And we identified that there were two significant drug use patterns that were predictors for meth mouth severity. The first drug use pattern is duration of use. Those who reported using methamphetamine for more than 10 years had statistically significantly more teeth affected by decay than those who reported using the drug for 1 year or less. So duration of use is a significant predictor of severity. The other significant predictor is route of administration. Amongst our population of methamphetamine users, we asked them what their primary route of administration was. Those who reported smoking methamphetamine, we categorized as an oral route of administration. Those who reported snorting or injecting methamphetamine, we categorized as a non-oral route of administration. And then we compared the amount of decay between those two groups. Those who were orally administering the drug, smoking the drug, had more teeth affected by decay than those who were bypassing the oral environment through intranasal or intravenous use. Now, I think that intuitively makes sense, because when someone is smoking the drug, that battery acid, that lantern fuel is coming into the oral environment, affecting the acidity of that environment. That smoke is so acidic and so corrosive that it creates a chemical burn on the enamel, causing that blackened decay. And when someone is smoking the drug, it's contacting the anterior teeth first. And that's why you see so many anterior teeth being involved. But in addition to duration of use, in addition to route of administration, there are a number of other behavioral factors that impact and help to explain this pattern of decay. In an earlier publication, Morio out of the University of Iowa reported that methamphetamine users were more likely to report never brushing their teeth compared to non-meth users, and as a result had more teeth with plaque and calculus. Now, if we go back into our pharmacology, we have high levels of dopamine that cause vasoconstriction of the salivary glands and cause a decrease in salivary flow. That decrease in salivary flow makes it difficult to neutralize the acidity, and the salivary pH drops. Now we have plaque being retained on the cervical and interproximal surfaces of the teeth. That plaque is sitting in a highly acidic environment, and as a result, those surfaces become demineralized, and that's why you see so many class 5 and class 3 lesions. And then, as I alluded to, the high levels of dopamine activate the neuromusculature of the temporomandibular joint, causing bruxism. About 85% of methamphetamine users report grinding their teeth both during and immediately after their meth use. So what's going to happen when you grind on teeth with class 5 lesions? They're going to fracture along the gum line. And that's why you see so many coronal fractures and retained root fragments in the mouths of individuals who are using methamphetamine. And then to add, once again, some additional fuel to the fire, when someone is using methamphetamine and they have those elevated levels of dopamine, after about 9 to 12 hours, the dopamine levels begin to plunge. And as the dopamine levels begin to plunge, the individuals start experiencing sugar cravings, because sugar pharmacologically mimics the action of an amphetamine. Sugar is able to trigger the release of dopamine. So by consuming sweetened foods and beverages, the individual is able to maintain elevated levels of dopamine. But the problem is the sugar serves as an additional source of acidity. So once again, it's the pharmacology, which is the key to allow you to begin to understand, but more importantly, recognize a patient who is sitting in your chair who may be using methamphetamine. But once you recognize the physical and the behavioral and the oral clues associated with methamphetamine abuse, you have to be able to communicate your concerns and your suspicions with your patients. Now, how many of you have a health history form in your practice? Now, of course, I can't see you, but I would imagine that everyone has their hand up and everyone is shaking their head. Of course you do. How many of you actually have a health history form that specifically asks about a history of substance use? Now, I can't see you, but I probably would imagine that maybe a few heads stopped nodding, maybe a few hands came down. This is one of the most important questions to have on your health history form. You actually want to have two questions. Do you have a history of substance abuse? And then the second question, if so, what type of drugs have you abused? Because now you have a more detailed response. If a patient responds yes to these questions, you have to know what to ask. And there are really three important questions that you want to ask that will help to maintain safety for your patient. The first question that you want to ask is, how long have you been using the drug? Once again, duration of use, as I shared with you, is a significant predictor of meth mouth severity, but also duration of use can help you understand where that patient might be in the spectrum of addiction. The longer someone has used a drug that's highly addictive, the greater the odds they develop an addiction to the drug. So ask about duration of use. The second question that you want to ask is, when was the last time you used? This answer may require that you put down your anesthetic syringe and you put down the dental drill. Methamphetamine has a half-life of about 10 to 12 hours, and it takes about 4 half-lives for 90 to 95% of the drug to be eliminated from the body. So if we do the math, 1 half-life is 10 to 12 hours, 4 half-lives is 40 to 48 hours. So it takes almost 2 days for methamphetamine to be eliminated from the body. So if a patient reports using methamphetamine within that 48-hour window of time, that patient's impaired. And that's a patient that you need to reschedule. The third question that you want to ask is, have you ever received treatment for your use? If a patient says yes, they're telling you they've been diagnosed with a substance use disorder that was of a magnitude that required intervention. If they tell you no, it gives you information about an opportunity to refer that patient to a trained professional who can help get them on a road that can lead to recovery. So you want to ask about duration of use, last time of use, and whether or not they've ever received treatment for their use. But in addition to using your health history form, I want you to understand this is a tool that helps you screen, but also helps you to initiate conversations. But I still want to give you a few strategies, a few secrets, if you will, that will help to facilitate further dialogue with your patients. The first thing is to be objective. One thing I can say about everyone on the webinar today is that you're really good about talking to your patients about diseases. Now, I can say that with a degree of confidence because that's what we do. We talk to our patients about their caries and their periodontal disease. We talk about their hypertension and their diabetes, and then we talk about that oral systemic link. And when we talk to our patients about diseases, we're objective, we're neutral. When you talk to your patients about addiction, you're talking about a disease. Be objective and be neutral. It'll help manage any emotional reaction that you might have to the topic. Once you ask the question, stop talking. Your patients will tell you everything and more than you ever wanted to know. And then you need to remember that what you say matters, but what you don't say matters even more. What you say matters. The words that we use matter. You want to avoid using words that have a negative stereotype or evoke some type of stigma. We don't want to use words that are labeling. We don't want to use the word addict or use the word alcoholic. Our patients are much more than their disease. The person sitting in your dental chair, someone's mother, someone's father, someone's husband, someone's sister, someone's teacher, someone's bus driver. The person sitting in your chair is a person with a substance use disorder. You want to refrain from using words that minimize the fact that it is a disease. So you don't want to call it a habit. It's a disease. And you also want to minimize using slang. You want to make sure that you use medical terminology. If you have to ask about a test result, you want to find out if the test results were positive or negative. So what you say matters, but what you don't say matters even more. Our patients are watching us. They're looking at our body language. And if our body language is communicating judgment, accusation, our arms are crossed, we're looking at our watch, we're not making eye contact. No matter what kind words come out of our mouths, it can never compete with a body language that's communicating judgment or accusation. So what you say matters, but what you don't say matters even more. So now let's talk about how to treat patients who have the oral effects of methamphetamine. When a patient opens their mouth and reveals teeth that are blackened and broken and grossly decayed, it can be overwhelming. It can be very difficult to know where to start or even how to prioritize the care. And you may have been waiting, I don't know, maybe even been hoping that I was going to share with you the secrets of how to get from here to there. Well, the secret's not in the treatment, but the secret's in your ability to plan treatment that takes into account your patient's risk for caries due to their drug use patterns. And let me say that again, the secret's not in the treatment, but it's in your ability to plan treatment that takes into account your patient's risk for caries due to their drug use pattern. Because you see, it's this analysis of risk that's going to determine treatment failure or treatment success. Now, in 2006, UC San Francisco, in collaboration with the California Dental Association, developed a medical model for caries management called CAMBRA, Caries Management by Risk Assessment. And this model asserts that the successful management of caries requires that you first determine if your patient presents with physical and behavioral findings that are statistically related to caries development. And if your patient presents with these characteristics, with these findings, you then assign your patient a level of risk, high, medium, or low. And it's only when that risk is known do you then plan treatment with interventions that target the patient at that level of risk, with the goal that over time, their future risk for caries will decrease. Now, when someone is using methamphetamine, there are a number of drug use patterns that increase their risk for caries. You've learned that duration of use is a significant predictor for caries severity. You learn that methamphetamine causes hyposalivation, and we know that xerostomia impacts caries. If a patient is co-abusing with other drugs, it might be mental health medication or antihypertensive medication, prescribed medication, or they're co-abusing with illegal drugs, cocaine, opioids, that also have a hyposalivatory effect that will further exacerbate the xerostomia that they're experiencing, putting them at a heightened risk for caries. You learn that when someone is using methamphetamine, they experience sugar cravings, which also will impact caries severity. Well, I pulled together a number of these drug use patterns, and I developed a form called the Meth Mouth Treatment Plan Assessment Form. And I developed the form once again with that premise that our treatment planning has to be guided by a caries risk assessment, and that caries risk assessment has to be guided by the drug use patterns of our patients. Now, I didn't develop this form to be prescriptive, meaning I don't want this form to replace your own clinical judgment. But I did develop the form to help you see and understand what treatment is likely going to be successful if your patient is at a certain level of risk, and what treatment is likely not going to be successful if your patient is at a designated level of risk. Now, you can download this form for free by just texting a state of decay to 22828, but you can do that later. I'd like you to just attend to how to use this form. So the first thing that you want to do is establish the risk level. You want to ask your patient about some behavioral things. You want to ask the patient, are they currently using methamphetamine? If they are, that's a high risk indicator. You want to ask about years of use. If they report using for more than 10 years, that's a high risk indicator. You want to ask if they've ever experienced a degree of sobriety during their drug use. If they report little to no sobriety, that's a high risk indicator, because it means they expose themselves to a highly acidic drug for an extended period of time without interruption. You want to determine if they're co-abusing with other drugs that impact salivary flow, whether it's illegal drugs or prescribed medication. You want to ask about their dieting and their snacking. And if they're doing a lot of in-between meal snacking, that's a high risk indicator. If they also report infrequent brushing, infrequent flossing, that's a high risk indicator, as well as if they report infrequent dental care utilization. You then want to do a clinical examination, and you want to look for the presence of heavy visible plaque. That's a high risk factor. You want to look for white spot lesions, which is indicative that the enamel is being demineralized. That's a high risk indicator. You want to look for the presence of advanced caries into the pulp, because if there's teeth with caries into the pulp, then there's likely other teeth in the dentition that are experiencing a cariogenic process. That's a high risk indicator. And if they have more than 10% of their dentition decayed, that's a high risk indicator. You then take a look at which column has the highest check marks, and that will be the designated level of risk for your patient. And it's only when that risk is determined are you now ready to plan interventions that target the patient at that level of risk. You want to have both home strategies as well as in-office strategies. In terms of home strategies, regardless of the risk level of the patient, you want to make sure you provide them with referrals for recovery or referrals for sobriety. And I'll share some resources for you in a few minutes. In the high-risk categories, you want to prescribe a highly fluoridated toothpaste. Elevate makes Floramax, which is a 5,000 parts per million toothpaste. By prescribing a product that they can use every single day, you're giving them access on a daily basis to a remineralizing product. Elevate's Floramax not only contains 5,000 parts per million, but also contains 10% xylitol, which is Caries inhibitory agent. So in one formulation, you've got both remineralizing and you've got something that is inhibiting caries development. Now, in the high-risk patients, you may also want to fabricate a custom tray where they can then place the Floramax in that custom tray and have a prolonged exposure to, once again, a remineralizing agent and something that is going to inhibit caries formation. You may want to consider recommending a mouthwash to the patient. Now, I would caution you to avoid recommending anything that is alcohol-based for a number of reasons. First, alcohol has a very drying effect on the oral mucosa. And if the patient is already experiencing hyposalivation, you don't want to have anything that will be further drying in the oral environment. But you also don't want to recommend an alcohol-based mouthwash because you don't want to recommend something that the patient could abuse by swallowing. So think about a 5% sodium fluoride mouthwash, or if that's cost prohibitive, the patient can make a home remedy. You know, a teaspoon of baking soda to an 8-ounce glass of water, and that bicarbonate rinse will actually neutralize and buffer the acidity. You want to provide dietary instructions. You want to recommend the decreased consumption of in-between meal snacking. In the high-risk categories, you may want to recommend the use of xylitol gum and xylitol mints. And then you want to address the hyposalivation. Elevate makes an all-day mouth spray that contains mucoadhesives that are wetting agents that can provide moisture to the oral environment. But in that formulation, it also contains 44% xylitol. So once again, in one formulation, you're addressing the hyposalivation and you're also addressing the caries. Once you have these home strategies, you now want to think about your in-office strategies. Regardless of the risk level of the patient, really be involved in oral hygiene instructions. Show your patients how to brush, how to floss. Never assume your patients know how to do it. In the high-risk categories, you want to have more touch points with these patients in your practice. So rather than saying, I'll see you in 6 months, you may want to see them every 3 to 4 months. Every 3 or 4 months for a hygiene visit. And you also want to have more frequent periodic oral examinations, which will allow you to determine if your interventions are being effective and moving that patient to a lower level of risk. I am a very huge and strong advocate for the use of topical fluorides. Elevate makes a Floramax varnish, which is the only 2.5% sodium fluoride formulation on the market. And even though it has a lower concentration of fluoride compared to the competitors at a 5%, at 2.5% level, it has more fluoride release in 1 hour, in 4 hours, and complete fluoride release in a 24-hour period of time. It also has a very thin film thickness, about 7 to 40 times less than a traditional varnish. So when it's applied, patients are very unaware of its presence, which decreases the risk of the patient wanting to leave the office and brush it off like they typically like to do with a traditional 5% concentration. It also is hydrophilic. It loves being in a moist environment. So you don't have to dry off the tooth or dry off the teeth in order to apply. I also love silver diamine fluoride. Silver diamine by itself is antimicrobial, and when combined with fluoride, it literally stops the progression of decay. I'll use silver diamine fluoride, I'll use advantage arrest, typically when I'm doing my caries control. I might be working, let's say, on the upper right quadrant, but I'm aware of a cavitated lesion in the lower left quadrant that I just don't have time to get to at that particular appointment. I first will make sure that the lesion does not involve the pulp, because you don't want to apply silver diamine fluoride if you have pulpal involvement. I also will make sure the patient does not have an allergic reaction to silver. I then will take a drop of Advantage Arrest on a microbrush. I will agitate it into the cavitated lesion for a minute, and then I'll air dry it, and I'll reschedule the patient. When the patient comes back, they're asymptomatic. And now I'm being just tasked with removing affected dentin. So it winds up being a much more comfortable appointment for my patient and a much more productive appointment for myself. So we have to remember that our topical fluorides are not just for our pediatric population, but our topical fluorides are so appropriate for our adult patients who are caries active due to their substance use. So start pulling out your topical fluorides. In terms of restorative and surgical and prosthetic treatment, I want to just provide you with a bit of an overview. In these high-risk cases, high risk means high chance for failure. The more complex your restorative, your prosthetic, your surgical treatment plan is, the more likely that complex treatment plan will encounter complications. In these high-risk categories, simplicity is more likely going to breed success. So when you're developing a treatment plan, I want you to remember the secret's not in the treatment, but it's in your ability to plan treatment that takes into account your patient's risk for caries due to their drug use patterns. But when a patient has, 5 teeth, 10 teeth, maybe even 15 teeth that are grossly decayed, these patients are in pain. And it's oftentimes this pain that fuels their continual use of a drug. Sometimes it's this pain that fuels drug-seeking behavior in our practices. But we have to make sure that we manage pain in a way that doesn't trigger a relapse if our patients are in recovery. We want to make sure we don't manage pain in a way that strengthens an existing addiction. And we also want to make sure that we manage pain in a way that's supported by evidence. In 2018, Moore published an article, it was a systematic review, in the Journal of the American Dental Association, where he pulled together data from multiple studies that investigated the effectiveness of analgesics alone or in combination with one another to decrease dental pain in terms of both intensity as well as duration. And when he did the systematic review, he concluded that ibuprofen alone or in combination with acetaminophen is more effective in reducing both intensity and duration of pain compared to opioid-based analgesics. So ibuprofen really should be the first line for managing acute dental pain. Now, I wish I could share with you that the methamphetamine epidemic is under control. And I wish I could share with you that over the last 25 years, I've had fewer patients walk through my door with lives and smiles that have been destroyed by this drug. But unfortunately, I can't share this good news with you because over the last 25 years, more and more of my patients, in fact, more and more of your patients, have walked into our offices with lives and smiles that have been damaged and destroyed by this drug. The use of methamphetamine is popping up in parts of this country that traditionally were never hot markets for the drug. We're seeing increases in states such as Rhode Island and New Jersey, increase of meth use in cities such as Atlanta, Detroit, Philadelphia, Chicago. Since 2008, there's been an increase in the number of emergency room visits due to meth-induced toxicity. Since 2011, more and more Americans have sought treatment for methamphetamine use disorder. Since 2016, more and more Americans are testing positive for methamphetamine on the work site. And since 2019, the number of deaths due to methamphetamine have more than doubled. Now, we can look at this data definitely from a lens of discouragement, from a lens of hopelessness. We also can look at this data from the lens there's just more work to be done. There's just more work to be done. We're a mighty profession. We treat millions of patients every single year. And just imagine if we start having courageous conversations with our patients, if we use our dental exam to begin to screen patients for a substance use disorder, if we develop treatment plans that include referrals to trained professionals who can address sobriety and recovery, just imagine. It might take 5 years, it might take 10 years, it might take 15 years. But we all might be able to say that we have fewer patients walking into our practices whose lives and smiles have been destroyed by this drug. And you start this process today because today you joined the webinar and you learn how to recognize the signs of methamphetamine abuse during a routine dental examination. You learn how to communicate your concerns and your suspicions with your patients by maintaining your objectivity and remembering that what you say matters, but what you don't say matters even more. And then you learn that the secret's not in the treatment, but it's in your ability to plan treatment that takes into account your patient's risk for caries due to their drug use patterns. But just knowing this is still not the same as doing it. So I'd like to provide you with a little bit of a to-do list of 4 action items that will make a difference for the lives of your patients. So I hope you have something to write with. Your first action item is to begin to screen your patients for a substance use disorder. Take a look at your health history form. If it doesn't have a question that specifically asks about a history of substance abuse, add this question to your health history form and do it today. When you're doing your dental examination, look for those white spot lesions. Look for hyposalivation. Look for blackened decay. Use your dental examination to begin to screen patients who may have a methamphetamine use disorder. Your first action item is to screen. Your next action item is to begin to educate your patients about the oral effects of methamphetamine. There's 2 things that can happen when you educate. The first is you might prevent someone from ever using the drug. And if you prevent someone from using methamphetamine, you have saved somebody's life. But for someone who is using, by educating them, you plant a seed of contemplation. And the more seeds that get planted from the dentist, the hygienist, the assistant, from the family member, from the friend, from the coworker, you're moving that individual one step closer to getting the help they need. The education can be in the form of a chairside conversation. It could be a social media post. It could be an article that you write for your practice. We have to begin to educate our patients. Your third action item is to have a mechanism for referral. I'd like you to write down this number. It's a toll-free number through the Substance Abuse and Mental Health Service Administration. That number is 1-800-662-HELP. If you have a patient that you're concerned about, give them this number. On the other end of the call will be a trained professional who can identify what your patient's needs are and then can direct them to resources in the community that can help them with sobriety or recovery. 1-800-662-HELP. And then if that meth mouth treatment plan assessment form can be of use for your practice, can help guide your thinking and your treating of patients who are at a heightened risk for caries. You can download it for free, once again, by just texting a state of decay to 22828. And then I'm going to add another action item. I want you to continue to learn about this. We have to make sure that we educate ourselves. My book, A State of Decay, Your Dental Guide to Understanding and Treating Meth Mouth, can be a resource for you in your practice, kind of like the elf on the shelf. When you're in your practice, if you're not quite sure how to have that courageous conversation, this book can remind you of what to say and how to say it. If you're not sure that what you're seeing may be due to methamphetamine, this book can help remind you of what to look out for. It's also a great training tool for your staff to help catch them up to speed on this topic. So I want to thank you for joining today's webinar, Catching Up to Speed. I thank you for your interest. And I also want to thank once again Elevate for sponsoring today's program. I'd like to turn it over to Haley Buckner, who will now moderate a Q&A. Thank you.
Thanks, Dr. Brown. And I can attest to your book as well. It's a very easy read. I read it on a cross-country flight, so definitely a good resource for offices to have on hand to refer back to. But we did have a couple of questions come in, not very many, because you, throughout the course, have answered most of the questions that came in. You were very thorough, so thank you for that. But just a couple of questions here. Are there other drugs that can cause similar meth mouth manifestations?
Really great question. I think that methamphetamine, that drug, is so distinct in terms of its presentation. You will find some interesting patterns of decay with opioid use. It typically will be more pinpoint, and you typically will see with opioid use more cuspal caries, which is a very unusual location for caries. But when someone is using opioids, and sometimes they are using, delivering it through almost like a pen cartridge, and they're sucking it into their mouth, the suction actually will direct the opioid, which typically is mixed with sugar, onto the cusp tips of mandibular, molar, and premolar teeth, creating these very small pinpoint carious lesions, which is very distinct, associated with opioid use. But the class 5 caries, the blackened decay, the class 3 lesions, the anterior tooth involvement really is so, I think, the hallmark of methamphetamine use. And I really have not seen it with other drugs.
Okay, very good. Thank you. And when you're talking about that blackened decay, is that blackened decay or that meth lesion, is it discernible from like an SDF treated lesion?
Yeah, because I think, with SDF, typically you're applying it in a localized spot, typically. And typically it will turn blackened as it's interfacing with cariogenic bacteria. But the blackened decay that you're seeing with methamphetamine use is just much more generalized throughout the dentition, which I think is really kind of a different presentation than the application that you see with an SDF. So I would say it does just look very, very distinct. And the other thing that you can always ask your patients is, did you have an application of SDF? And once again, it's really important, Haley, and I want to piggyback, it's really important that we're looking at a multitude of things, right? So it's not just what we see in the mouth, but it's what's happening before we get to the mouth. It's having those questions on the health history form. It's looking at the patient's behavior, looking at the vital signs, looking at pupils that are dilated, looking at change of appearance of the patient. So there's a lot of things that we have to kind of put into play to recognize a patient who may be using methamphetamine. And it's having those conversations with the patients, being curious and asking those questions.
Very good, thank you. And then the last question we have for you here is, do users respond well to basic oral hygiene instruction? For example, something to offset their increased sugar cravings.
So I'm gonna see if I can answer this question. I'm not sure I understand it in its entirety, but I think patients can be very motivated about their oral hygiene when you really have, really candid and caring conversations with them about the impact that methamphetamine is having on their dentition. And, it's talking about the importance of daily oral hygiene, the impact that the decrease in salivary flow is having. Sometimes we have to have real conversations, make sure you take a toothbrush with you. Make sure you brush your teeth, make sure you drink lots of water. And then once again, having an increased frequent recall for hygiene visits with these patients in your practice. So I think every patient's going to be different in terms of their response. We see it with patients who may be using methamphetamine and patients who don't use methamphetamine. All of our patients respond differently to oral hygiene, but I really feel about the power of education. When you're able to have those frank conversations and show them the damage that's happening, and try to empower them with tools on a daily basis that will help to mitigate those effects, it can be very powerful and very changing for the patient.
Great. Well, thank you so much. And just thank you for a wonderful presentation this evening, Dr. Brown. And also thank you all for joining and spending your Tuesday evening with us. And then also for those of you that are in the path of this hurricane, our thoughts and prayers are with you all in your communities this week and into the weekend. And then as far as your CE certificate, for those of you on here, your CE certificate will be emailed automatically within an hour or two. So also be sure to check your spam folder if you don't initially see it. And then also like us on Facebook and Instagram for links to new free CE events. The website that we mentioned in the beginning, the elevateoralcare.com/elevatingcare, will give you access to our archived webinars, including this evening's webinar, which should be accessible in just a few short weeks. So please share this link with your staff and colleagues. And finally, on our Elevate Oral Care website, you will find buttons to request an informative CE-eligible staff meeting for your office. Education on the latest evidence in oral health prevention is what we do, and we would be honored to meet with you and your team to help you best serve your patients. So thank you all. Have a wonderful rest of your week, and we hope to see you on our next Elevating Care webinar next month on October 25th at 8 p.m. Eastern Standard Time. Thanks again, Dr. Brown.
Thank you. Good night.